Hello everyone, welcome to a very important day, and we are here to discuss about the NEET PG 2023 orthopedic questions, all right, based on the recall obviously. And hopefully you have managed, the questions were relatively easier, the questions were relatively related to the means day to day what you tend to see in your orthopedic practice, as I'm saying repeatedly that this is going to happen and it will be reflected in your examinations too. And this is exactly how the pattern questions out of this subject, that is orthopedics, were, all right. So let's have a discussion on the questions which were asked today. The first question was related to a tumor and its deformity. All right. Now, before even talking about the question, you see, it is a typical picture which was provided to you in the form of the X-rays. And just on the basis of that, you would be able to manage it that, this was the answer for this question without thinking, without having too much of doubt related to it. And there was an associated lesion also provided to you. All right. There was a skin lesion also, which was given to you in the form of a hint. So combining both of them, you will be reaching the correct answer for your particular question. Now, answer for this question, which was provided along with this X-rays, was fibrous dysplasia. The patient having a progressive deformity with abnormal skin lesions having irregular margins. So what is the most probable diagnosis with the kind of the X-ray provided? Now, let us have a discussion on that why exactly this thing happens. All right. Although you are aware that this deformity, that is Shepherd-Crook deformity in the proximal aspect of the femur is due to fibrous dysplasia. All right, you are aware of it. Like normally the femur is like this, but here in this case it will be having a Shepherd-Crook deformity like this. All right, it will be deformed like this. Now, what is the reason for this kind of the deformity? This is something that is the additional point to be discussed. All right. So if we talk about fibrous dysplasia pathology, you see what happens in fibrous dysplasia, the cells which are to be differentiated into, if we discuss the histopathological examination, the cells which are differentiated into like osteocytes, all right, osteoblasts, or like adipocytes, or the bone marrow cells. So there is no clear-cut distinction, as a result of which this progenitor cells, the progenitor cells are getting converted into undifferentiated cells, undifferentiated bone cells, and these undifferentiated bone cells ultimately will result in the formation of osteofibrous tissues. So instead of a differentiated cell that has to be present at that particular site of the bone, there is a formation of the osteofibrous tissues, means abnormal cells which are taking the position where the differentiated cells of the bones should be there. So as a result of which, why this abnormality is having the features in the proximal aspect of the femur only. Like if it is present in the femur, then why is it having such kind of the abnormality, or why the Shepherd-Crook kind of a deformity exists in the femur because of this problem? Now for that, just try to understand. Imagine this is a femur where there is a head of the femur, neck of femur, this is greater trochanter, lesser trochanter, and this is the shaft of the femur with the condylar regions like that. All right. So this obviously is the medial part and this one is the lateral part. Now already you are aware, like in case of any weight bearing zone of the bone or in weight bearing bone, these two cortices are not similar. The medial and the lateral cortices are not similar. The medial cortex, because it is nearer to the weight bearing axis, is a compressive cortex. All right. So each and every part of this medial aspect of the femur is under compression. The force which the body weight is applying to the femur, and a counter force which is applied by the ground, all right, anti-gravity forces. So every part of the inner segment of the femur is a compressive cortex. So the inner femur is basically the compressive cortex. That means the medial aspect of the femur is compressive, while the outer aspect of the femur is tensile. All right, because if one segment of the structure which could be compressed, the other segment will become more tensile, it is distractive. Now just imagine if in this region, what is happening, that this region is replaced by undifferentiated cells which are not mature enough to commit the normal functions of the bone. Now here we are having a fibro-osseous kind of a tissue. So when the weight is applied to this fibro-osseous tissue for a long duration of time, under the influence of compression, it will lose its shape, as a result of which there will be a progressive bending of the femur. All right. So this is how it will progressively bend. under the influence of the weight. And this is the reason for the Shepherd-Crook deformity. All right. Hope you have understood everything related to that, how the Shepherd-Crook deformity is happening in case of fibrous dysplasia. For that, you have to understand that what was the pathogenetic feature. The histopathological examination revealed that the bone marrow biopsy revealed that there is a bone marrow cells are replaced by a fibrous tissue. There are too many fibrous tissue, and these osteofibrous network, which are undifferentiated cells, they are not responsible for the normal functioning of the bone. As a result of which, under the influence of the weight, there is a progressive deformity that is happening. All right. So here, the normal femur is obviously it is not the normal femur, and as you can see that there is a curvatural bending on the medial cortex of the femur under the influence of the compressions. So that is the reason for Shepherd-Crook deformity. Another point which was clearly mentioned in the question are irregular margins, skin lesions. Now, what are these skin lesions which are likely to have the irregular margins? These are café-au-lait spots. It is nothing but the café-au-lait spot. Now, all of you know that the café-au-lait spot basically are the coffee colored spots which are or which could be distributed over the trunk, abdomen or axilla. Now, these coffee colored spots are basically a feature of McCune-Albright syndrome. All right. And McCune-Albright syndrome, one of the component is fibrous dysplasia. So hopefully everything is clear related to this particular question, because if associated with fibrous dysplasia, there could be a café-au-lait spot over the lesion over the skin also. So what is McCune-Albright syndrome? Now, this is something which you might have studied in gynecological studies also, McCune-Albright syndrome. So the components basically are polyostotic fibrous dysplasia. So one of the component is fibrous dysplasia. Second is café-au-lait spot. Now, you know, this café-au-lait spot over here are having irregular margins. Irregular margins. Like this is irregular margin and this is a regular margin. Café-au-lait spot is a condition which is prevalent or which you can see in two types of diseases. One is McCune-Albright syndrome, that is fibrous dysplasia associated. Other one is neurofibromatosis type 1. You already know about it. That neurofibromatosis type 1 also presents with this café-au-lait spot. But what is the difference? In neurofibromatosis type 1, they are having regular margins. All right. So regular margins are a feature of neurofibromatosis type 1, while irregular margins is a feature of McCune-Albright syndrome or association with the fibrous dysplasia. That is also a reason, you know, this is also called by the name of, you know, coast of Maine and coast of California. I mean, the coast of California, which could be having a regular coastline. So it is the reason why these kind of spots are called as coast of California, while in case of polyostotic fibrous dysplasia, it is called by the name of coast of Maine. So this is something that you already know about it. Yes, there is a third component also, like earlier appearance of a secondary sexual characteristics in case of females. So it is basically the precocious puberty. Hopefully everything is clear related to this particular topic. You know, it was a simplest question asked in the form of a tumor, like they gave the X-ray with a clear-cut Shepherd-Crook deformity, and they also mentioned that there was an associated skin lesion over the skin that has got the irregular margins. All right. So this is what the reason, and you came to know under this segment, you came to know about the pathogenesis, the reason for that. You came to know the associated factors related to this fibrous dysplasia. It could be monoostotic or polyostotic, obviously. All right. So hopefully everything is clear related to this question number 1 in orthopedics. Now, next question. Again, a very practical question. Like, you know, as I told you, and repeatedly I am saying that at least one question is going to be asked. You know, at least one question is going to be asked from the peripheral nerve injury. That means from the injuries around the hand. All right. And for that, intrinsic muscles of the hand are playing a very important role, because all these tests are related to the anatomical aspect of the intrinsic hand muscles. Now, what was the question? The question was clearly related to the carpal tunnel syndrome. Like, the question is simple, like there was a sensory loss over the lateral 3.5 digits in the hand. What was the diagnosis and what is the test for, by performing this, you will confirm that this is the probable diagnosis the patient could be having. And it is a very common phenomena to be seen on day-to-day basis. Now, if you look at the options, the first one, obviously the answer, first thing is the answer, that it is the carpal tunnel syndrome that we are going to talk about. All right. You know that carpal tunnel syndrome, there is a compression of the median nerve under the flexor retinaculum, and the median nerve is responsible for predominantly supplying the sensations to the 3.5 of the hand. All right, this region. So if there is a compression of the median nerve, so there are going to be sensory abnormalities in the form of tingling, in the form of numbness, variable paresthesias. All right. Now what you do is that if you perform a manual compression, all right, that you manually compress this median nerve as an examiner or as an orthopedician or as a physician, you compress this structure, all right, wrist, you put the pressure over the course of the median nerve for the period of 30 seconds. What will happen? That there will be more abnormalities, all these sensory abnormalities are going to be exaggerated. So this is exactly what the Durkheim's test is, all right. So what the test is, that there is a manual compression, all right, manual compression over the median nerve for the period of around 30 seconds, and all these features of the median nerve compression are going to get over exaggerated. So this is exactly the answer for your question. Now, if we talk about other options, like you came to know that the answer for this question is A, that it is a carpal tunnel syndrome and the Durkheim test positivity is there. All right. Now, if we talk about the other options, like the option second is that is it the carpal tunnel syndrome? Answer is 2. But is it the Froment sign? You know what is Froment sign? The Froment sign basically is the modification of the book test. All right. And Froment sign is done in case of ulnar nerve injury. Now, what happens in case of Froment sign? Just try to understand. Imagine if you ask a patient to hold the book by adductor pollicis, that means by adduction of the thumb. You ask a patient to hold the book by adduction of the thumb, and the examiner is trying to pull this book out. Ask a patient to apply resistance to that pulling movement. If he is not able to apply the resistance, it means adductor function of the thumb is lost. And adductor function of the thumb is the function of the ulnar nerve, because that is one feeder muscle which is not supplied by the median nerve. It is supplied by ulnar nerve. All right. So it is the test for ulnar nerve positivity. But you know, as a patient, the patient is not going to think about that what is ulnar nerve and how is it being tested. What he is getting from you is that you just have to hold it, all right, tightly. You have to hold it tightly, and as an examiner, you have to pull it out. All right. If the patient is not able to apply adequate resistance, then he will use another muscle to hold it tightly. And what is that? The flexor pollicis longus muscle. That flexor pollicis longus is supplied by median nerve. Understood? And now the patient can apply some resistance. So hopefully you have understood what the importance of the Froment sign is. So Froment sign directly is related to the ulnar nerve injury when we are testing about the ulnar nerve. All right. The Durkheim test simply is the compression of the median nerve, and there will be over exaggeration of the features or the symptoms. Yes, in case of Guyan canal syndrome, ulnar nerve is getting compressed. So hopefully you get the answer for this question straight away. Means there is another test. One of the tests is Durkheim's test for the carpal tunnel syndrome. The another test is Fallon test. All right. That is also for carpal tunnel syndrome. And what you do in Fallon test, you will flex both the wrists against each other. You will apply the pressure. And all right, so there will be more resistance applied, as a result of which there will be more compression on already compressed median nerve. So that will again exaggerate the sensory features the patient is experiencing. So hopefully you get the answer for the questions out of the second very easy question, again practical question. All right, the answer for this question, that the test is Durkheim's and the diagnosis is carpal tunnel syndrome. All right, coming on to the next question. Now, again, this is a kind of the question which does not require too much of the explanation. But you know, before we talk about this question, let me have a discussion of one primitive kind of a question where they used to ask the one-liners, all right, in orthopedics. And the question was that foot drop is a feature of, all right. They used to ask this question, that which of the following nerve injury will result in a foot drop? Hopefully you have understood or you have recalled. I mean, in 2010, 2011, that was the time where they used to ask these kind of one-liners. Foot drop is a feature of. And out of multiple options, 2 options were very commonly given. One was common peroneal nerve and the other one was deep peroneal nerve. All right, common and the deep peroneal nerve. Now, as a student, you know that deep peroneal is a branch of common peroneal, and the tibialis anterior muscle is supplied by common peroneal nerve. Means overall it is supplied by the common peroneal nerve. And then common peroneal gives the 2 branches. You know, common peroneal gives the 2 branches. One is superficial peroneal nerve and the other one is the deep peroneal nerve. All right. So deep peroneal, majority of the cases, is responsible for giving a branch to the tibialis anterior. But you know, in some of the cases, or you can say there is also a possibility that the nerve to tibialis anterior is directly emerging from the common peroneal before it gets divided into 2. So that is also a possibility. So in that case, what you are getting is that it is not necessary that only the deep peroneal is going to be injured. Then only it will lead to a common and then only it will lead to a foot drop. Rather, when the common peroneal nerve is injured, then in any case the foot drop has to be there if there is an injury to the common peroneal nerve. All right. So that was the essence of asking this question. So answer in any case, the answer for that question will remain the common peroneal nerve, because there are anatomical variations that the tibialis anterior could receive its branch from the common peroneal also and from deep peroneal also. But in case the deep peroneal is injured where the branch to the common tibialis anterior was already given, in that case there will be no foot drop. But if the common peroneal is injured, then in any case the patient is going to have a foot drop. So answer was common peroneal nerve injury. Now, if you look at the course of the common peroneal nerve, you know, this common peroneal nerve, it goes behind at the head of the fibula, and just after descending for some extent, it divides into two of its branches. All right. So near the proximal aspect of the fibula, there is a common peroneal nerve, as well as there is a division of this nerve into deep peroneal and common peroneal. And you know, hundreds or multiples of the time we have discussed this concept that if there is any injury which is affecting the proximal aspect of the fibula, it will result in an injury to the tibialis anterior, because that tibialis anterior is the major dorsiflexor of the ankle. And if there is a loss of tibialis anterior functioning, that means if there is a tibialis anterior palsy, the patient is going to have a foot drop. Now come back to the question. The question is that following the landmarks are around the knee joint. Now they gave you some of the landmarks like 1, 2, 3 and 4. Point the area that will cause failure of the ankle dorsiflexion. Point the area where if that area is injured, it will result in the failure of the ankle dorsiflexion. So everything you came to know about this particular topic, that first point that you came to know was that, you know, that tibialis anterior is the major dorsiflexor of the ankle. All right, major dorsiflexor of the ankle. If the tibialis anterior, and this tibialis anterior is supplied by the common peroneal nerve or the deep peroneal nerve. But yes, preference has to be given to a common peroneal nerve, because in any case, if there is a variation also, then in any case tibialis anterior is going to be paralyzed if there is an injury to the common peroneal nerve. So if there is an injury to this tibialis anterior muscle, then what it will lead to? The patient is going to have a plantarly flexed foot, and that condition is known as foot drop. So remember one more point, that foot drop is not plantarly flexed foot. Foot drop is inability to dorsiflex the ankle. So actually, by defining a foot drop, you should also define the pathophysiological mechanism behind. All right. So foot drop is inability to extend or inability to dorsiflex the ankle, and it is because of tibialis anterior palsy. As the anatomical perspective of this particular question we have already discussed. So answer for this question goes to 3. Now for this particular question, we are having this arrow mark which is around the proximal aspect of the fibula. All right. So if there is any injury along the proximal aspect of the fibula, it is going to have an injury to the tibialis anterior branch. All right. So answer for this question is around the, whichever is proximal to the proximal aspect of the fibula, because this is where the common peroneal nerve palsy might result in a foot drop. All right. So hope everything is clear related to this particular question also. Under this question or under this segment, what you came to know about, point number 1, that there should be no confusion in between common and the deep peroneal nerve, that what is the answer that has to be marked. You came to know the muscle which is responsible for supplying, which is responsible for the ankle dorsiflexion, and you came to know what exactly is foot drop. And you know, there are hundreds of the questions which could be associated with this particular topic. It is a very common phenomena that you will see in day-to-day examinations as far as your OPDs are concerned. All right. So with this third question, which was probably asked, which was asked in orthopedic examination or the orthopedics in NEET PG 2023, we have covered this also. Yes, next is again a kind of the question which you are getting every year. You are getting this question. You know, they will give you a epiphyseal tumor. They have specifically mentioned the age of the patient, which is more than 20 years of age, and then they are asking you what is the name of the tumor that you are visualizing over here. You know, in case the INI-CET examination, this was the question which was asked, and there they were asking several of the things related to giant cell tumor, like will it metastasize, is it going to have the malignant tendency. All right, these were the kind of the options. Here it is just for the purpose of identification. Remember, it is not very difficult that whenever you see the epiphyseal tumor, this is something which we have talked multiple of the times. Whenever you see the epiphyseal tumor, it could be either a GCT or a chondroblastoma. All right, it could be either a GCT or a chondroblastoma. So how to differentiate in between the two? I mean, the X-ray appearances obviously are going to be different because GCT is an aggressive benign tumor. It is going to involve a larger segment of the bone. It is a rapidly progressive kind of the tumor. It is an eccentric kind of the tumor, which will push the normal margins of the bones also. But you know, in order to make the diagnosis, what you have to look for is the growth plate, because if the age is more than 20 years of age, then probably it is GCT. While if the age is less than 20 years of age, where the growth plates are still visible, they are not fused yet, or there is no obliteration of the growth plate, in that scenario or in that case, the answer for that question goes in the favor of chondroblastoma. So here, as you can very clearly see, that the tumor was given in the distal end of the ulna, where the epiphyseal involvement was already there. But because it is an aggressive kind of a benign tumor, which can be converted into a malignant tumor also, so the involvement could be radical, all right, related to this GCT. And don't try to compare it with the theoretical appearance, like soap bubble appearance for GCT means. In order to make the diagnosis, that is not the correct approach. The correct approach has to be, you have to look for the growth plate. If the growth plate is visible, then it is not GCT. If the growth plate is fused already, then probably that epiphyseal tumor is a giant cell tumor. I mean, this was the kind of the question which does not require too much of the explanation, because every year you are getting this question out of this topic orthopedics. All right. Yeah, one more point if you want to add, because that is something which was asked in INI-CET recent examination, that you know, metaphyseal GCT. Every time we tend to see about the GCT tumors, it is epiphyseal tumor. Yes, right. But what about the metaphyseal GCT? Is it a possibility? So you see, if the GCT is appearing earlier in the course, like if the GCT is happening in an adolescent individual, then it could be a metaphyseal GCT also. So young age, although this phenomena is too rare to happen. And yes, one more point which is important for us to discuss is that GCT is a kind of a benign tumor. Now, still remaining benign, it can metastasize. All right. So GCT, even when it is benign, it can metastasize. So metastasis is a possibility. All right. Just try to understand this important concept. Now, because metastatic lesion or metastasis is usually a feature of a malignant tumor, but because GCT is a benign tumor, there is also a possibility that this benign tumor can metastasize. And what kind of a benign GCT can metastasize? Probably the distal radial. All right, distal radius. And what is the possibility? The 3% is the possibility. So you combine all the statement is that although it is a benign tumor, but GCT can also metastasize to involve the distant organ like lungs, but the possibility is just 3%. And out of multiple lesions or multiple locations where GCT can happen, the distal radial GCT is more likely to go for metastasis. So hopefully you have understood everything related to this GCT topic. All right. This is a kind of the topic when you sit in the examination, or before even you sit in the examination, you are very much sure that you are going to get a question out of this GCT, the giant cell tumor. All right. Yes, next question, which is again very interesting. You know, this is the kind of the question which they have asked probably for the first time, because every time you see a question related to the patella fracture, they are asking about the tension band wiring. All right. Now, before we talk about this question, first of all, let us discuss the understanding of what the question was saying. All right. Now, if you look at this question, which of the following is true for the given image? Now, they gave you the image, and then they are asking that which of the following suits with the provided image. Among the options, what is the correct answer? What probably is the correct answer? What probably could be the correct answer for that? Now, before that, if there is a fracture in the patella, all right, then that fracture of the patella, there has to be a question given, like there is a history of injury. So point number 1, no history of injury given to you. All right. Point number 2, whenever there is a fracture in the patella, it is going to be either transverse or comminuted. So here there is no transverse fracture which is provided, because majority of the time what you get is either a transverse fracture or a comminuted fracture. So in this question, there is Neither a transverse kind of a pattern fracture is given, nor a comminuted kind of a fracture pattern is given. All right. So point number 1 is that is it the fracture of patella? Answer for that question is no, it is not the fracture of patella. We are not talking about the patella fractures. What is the condition that we are talking about is a bipartite patella. All right. So what do you mean by this statement, bipartite patella? You know, when there is a lack of fusion, when there is it is considered to be a developmental abnormality, where there is no fusion among the poles of the patella, as a result of which the small segment of the patella, more commonly superolaterally, all right, superolateral pole of the patella, it remains unfused with the parent bone. Now, what if we tend to see over here in the X-ray which is provided? This is the AP view and this is the skyline view. Now, in the AP view, it is very much clearly evident that this is the patella shadow. And here in the patella shadow, this is a small segment of the bone over here. It is separated from the parent bone. And similarly, it is confirmed when you get the skyline view done. Because in the skyline view, you tend to see the superolateral pole of the patella, which is separated from the parent bone. Now, there is no history of injury. In case of transverse fracture, this is the kind of the fracture that the patient could be having with the displacement. In case of comminuted fracture, there could be a comminution of the bone into multiple pieces. But this is exactly not the scenario, not the case in this case. All right. So what is the probable answer? First of all, you have ruled it out that there is no fracture of the patella. Then what is the possible answer for this question? If you look at the option number 1, superior pole patella fracture which requires cylindrical cast for the period of 3 weeks, obviously no, this is not the answer because this is not the fracture of the patella. Second, patella fracture tensionment wiring, no, because this is not the fracture of the patella, no tensionment wiring is required. Is it the avulsion fracture which requires nail fixation? Even if this is a fracture, all right, if there has been a fracture in the superolateral pole of the patella, even that, the nail fixation is not required, K-wire fixation is not required. You can just manage it conservatively, all right, because the articular surface or the biomechanics of the knee joint are not going to be affected much. And finally, what you are left with is the answer for this question, that actually it is the bipartite patella, that means unfused pole of the patella. And what you need to have is the bilateral knee X-rays, because majority of the time you just try to understand what is bipartite patella. In this case, what happens? The clinical feature is that majority of the time there are no symptoms at all. All right, the patient is asymptomatic. It is a developmental abnormality and the patient is not presenting with any kind of the symptoms. So how will you diagnose it? Majority of the time it is the incidental finding. You know, if the patient comes with any other condition, and you go for the X-ray, so majority of the time it is the incidental finding. Once it is confirmed that you are seeing a bipartite patella, then what you will go for the bilateral X-rays. All right, you will go for the X-ray of the other knee also, because you want to confirm it, whether it is really an unfused projection of the bone or really an old-time fracture might have happened. So if the other X-rays are absolutely normal, then possibly it was because of. So in order to make the correct diagnosis, you have to get the X-rays of both the knees done. So hopefully you have understood this concept also related to this particular topic. It was a very conceptual question asked. I mean, simplest in the form, as if you are sitting in the OPD watching the patient. What is the next step that you have to go for? All right. So before performing this question, what you had to rule out first was that it was not a fracture related question. All right. Hopefully everything is clear. Now, how will you treat? Yes, you might be wondering that how will you treat this condition, the treatment? You know, if it is asymptomatic, obviously no treatment is required. All right, you just have to go for the exercises. But yes, in case if it is symptomatic, if there is too much of pain and there is an instability, then now based on the biomechanics of the knee joint, you can go with the management options. All right. So everything possibly is clear related to that topic number 5th also, or the question number 5th also, that was bipartite patella. All right, and the approach of that particular question also. Next is, you see, again, as I'm repeatedly saying that, you know, this is the kind of the topic which each and every one of you should be aware of, not just the clinical features, not just the management options, not just with the X-ray findings, means not just theoretically, but practically also. You see, because you are in the age group, like 20 to 25 years of age, you are in the age group where this thing starts happening, starts developing. And if it is not taken care of adequately, then it will lead to a permanent disability. The topic that we are talking about is ankylosing spondylitis. And, you know, this is the reason why the examiner is asking this topic in particular again. again and again, because he wants you to be aware of this deleterious condition, which is, to some extent, you can prevent the patient from landing up in disability. All right, because once the joints they get fused permanently, then there is no alternative left, and then you have to go for corrective surgical methods only. As the name indicates, ankylosing means fusion, so it is a pathological fusion. Ankylosing, it represents the pathological fusion. So SPOND is the word which is used for axial skeleton. So basically SPOND is axial skeleton. All right, and itis is the inflammatory pathology. All of you are aware of this. So basically it is the inflammatory pathology of the axial skeleton which ultimately will result in the ankylosis, that is pathological fusion. All right, so leading to it means related to it, there are numerous clinical features, like there will be pain in the sacroiliac joint. The most important clinical feature that you should be knowing about is the pain in sacroiliac joint. All right, now other features also, like there will be back pain, and obviously there is going to be a disability in the form that there is first limitation of extension of the spine. The patient won't be able to extend the spine completely. So there are multiple tests on the basis of which you are going to confirm it. All right, so that is a clinical feature that you have to take into account or consider them. But at the same time, there are extra articular clinical features also. Now if we ask you to remember this table, extra articular clinical features, when we have discussed this question in the another session on YouTube, we have discussed it by comparing it with the tuberculosis, and I told you that if you get a question related to ankylosing spondylitis, they will give you extra articular features. All right, while in case of tuberculosis, they are going to give you a constitutional features like fever, weight loss, loss of appetite, anorexia, the continuous weakness, and the neurological features in case of tuberculosis. While in case of ankylosing spondylitis, extra articular manifestations are to be provided in order to make you reach the correct diagnosis for that particular question. And this is exactly what has happened in this question. I mean, they gave you the extra articular features, like they gave you the limited chest expansion, they gave you the red eyes, that means uveitis. So extra articular clinical features for ankylosing spondylitis, the first one is acute anterior uveitis. And you know that acute anterior uveitis is the most common extra articular feature. Apart from this, the patient could be having a cataract also. The patient could be having a glaucoma also. All right, so these are the ocular features. Then there are cardiac features like third degree heart block. The patient could be having a third degree heart block, as well as aortic valvular insufficiency. All right, aortic valvular insufficiency. And they have asked this question multiple of the time, like which of the following is not a feature of ankylosing spondylitis? So dilated cardiomyopathy obviously was the answer for that question. Then apical pulmonary fibrosis. All right, so these are the things that you should be aware of. Apical pulmonary fibrosis. Because of this fibrosis, there is a limitation of the chest expansion. Moreover, because of this, this is the reason for the limitation of the chest expansion. This is point number one. Other reason is that, these costochondral junction, they start getting fused. And because of the fusion of the costochondral junction, there is a limited expansion of the chest. All right. So normal, you say, for example, it is around 5 to 7 centimeter. Here in question, it was provided around 3 centimeter. So there is a limited chest expansion on inspiration. All right. Apart from this, there could be prostatitis. The patient could be developing a prostatitis. All right. Then retroperitoneal fibrosis. All right. So these are the extra articular features. These are the extra articular manifestations of ankylosing spondylitis that you should be aware of. I mean, they are extremely, extremely important for you to remember. All right. Now, if you go back to the question again, that what they gave already, like a 40-year-old male, yes, 40-year, because by this time the fusion has already happened. The 40-year-old male presented with a history of long-standing back pain, persisted early morning stiffness. On examination, chest expansion was 3 centimeter on inhalation. All right. And there was a feature of redness of the eye also, and they also gave you the x-ray. And all of you know, all of you are aware of the fact that what you are going to get on the x-rays in the later x-ray findings. So as far as the x-rays for your questions are concerned, you have to remember these two findings in particular. All right. Point number one, the calcification of the soft tissues. Calcification of the soft tissues. Now all the soft tissues around the vertebral column, they are getting calcified. So there will be a calcification of intervertebral disc, there will be a calcification of interspinous ligament, there will be a calcification of anterior and the posterior longitudinal ligament, as a result of which the bone will appear in continuity. You see, all these structures which were not meant to be calcified, when they are calcified, there will be a bone appearance in the continuity. The bone will appear in a continuity, as if you are watching the trunk of the bamboo, and that is the reason why it is called by the name of bamboo spine. All right. So fusion of all intervertebral discs leading to immobile, rigidly fixed spine. So this is the end result of ankylosing spondylitis with a residual deformity. It could be a kyphotic deformity majority of the times. All right. So hopefully you get the answer, or you have understood the concept behind this question, ankylosing spondylitis. Remember, as a student, as in the age group, as a medical professional, you should be aware of the effects. And the treatment is relatively simple. The treatment is simple. The treatment is just you have to put the patient on sternus exercises. Just ask him to move every joint morning and evening, so that this movement only will limit the fusion of the joint. All right. So exercise is the mainstay of the management, along with the non-steroidal anti-inflammatory drug. Indomethacin is particularly used for this. All right. So as in this age group, because you know the condition, you are aware of its effect, and you are aware of the simple treatment also. That is why the question is persistently being asked in your examination. All right. So this is something that you should be aware of, ankylosing spondylitis. Extra-articular clinical features are extremely important for you to remember. Hope everything is clear related to this particular topic also. Next question. Coming on to the next question. Yes, they gave you a simple splint, and then they are asking that what is the probable indication for this splint. First of all, you see, whenever you get a question related to splint, so there has to be approach. All right. What is the approach for identification of a splint? All right. Whenever you see the splint, first of all, look at the position of the joint in which it is immobilized. Just try to understand. Here in this case, this wrist joint is immobilized. The metacarpophalangeal joints are immobilized. But what is the position in which it is immobilized? So in this case, as you can say, the wrist is immobilized in extension, that means the dorsiflexion, and the metacarpophalangeal joints are also immobilized in extension. All right. So both of them, that means the wrist and the metacarpophalangeal joint, both of them are immobilized in extension. That means there has been a nerve injury, because of which there is a muscular paralysis, and those muscles were extensors of the wrist and extensors of the metacarpophalangeal joint. Because of the loss of extension, the patient was having this kind of the deformity, and this is known as wrist drop. So here, by placement of the splint, you are preventing this wrist drop from getting permanent. All right. In order to keep the joint passively mobile, you are immobilizing it in the function of its lost, in the position of its lost function. So by the time you realize that it is the extension of the wrist and extension of the metacarpophalangeal joint which is achieved by the placement of a splint, by this time you already know the answer. All right. Extension of the wrist, extension of the metacarpophalangeal joint, it was lost. That is why the splint is kept, and extension of the wrist and the metacarpophalangeal joint is the function of the radial nerve. And if there is a radial nerve injury, it will lead to a wrist drop, and this wrist drop need to be immobilized in a correct position by, what is the name of this splint for the radial nerve? It is cock-up splint. So this is the approach that you have to proceed with. All right. First of all, look at the joint in which they are immobilized. If the extension of the wrist, extension of the metacarpophalangeal joint, they are immobilized in this extension, it means that there is a nerve injury which was responsible for extension of both these two joints. And now you came to know the nerve injury, you will come to know about the name of these splints also. All right. So this is cock-up splint. So here what we are seeing over here is the dynamic cock-up splint. Now, what do you mean by the term dynamic cock-up splint? Because these are the strings which are attached. It is designed in the way that when you flex, there is a rebound contraction again. When you flex, there will be a rebound contraction. So not only immobilization, there is a possible movement of the fingers also. That is dynamic. Had there been no string attached, just a slab you put in the extension of the wrist and the metacarpophalangeal, that will be called as static cock-up splint. But this is something that you came to know about, that it is a cock-up splint related to radial nerve injury. One more thing which is extremely important that you should be knowing as a generalized concept, that splints, they are never used. Splints are actually never used used to correct the deformity. When we apply the splint, we are never using the splint to correct the deformity. It's not like that the nerve will start functioning normally when the splint is applied. Splints are generally applied to prevent the abnormality from getting permanent. All right. So what is the use of a splint? It is to prevent the persistent deformity or to prevent the permanent deformity. Permanent deformity. So this is the use of a splint. Remember, every time you see a splint in orthopedic practice, it is used to prevent the development of a permanent deformity. It is never used to correct the deformities. Here we are preventing the persistent plantar flexion. All right. Next question. They have asked one question that 8-year-old who was already diagnosed with the scurvy, and there was decreased wound healing, bleeding gums, and there could be pain in and around the joints also. So what could be the possible reason? Now, just a basic understanding of the reason is, the collagen of the bone, the major collagen of the bone is collagen type 1. And if this is the amino acid, this is the amino acid, all these amino acids are integrated in their original form. But this proline and lysine are the two amino acids which are not integrated in its original form. They are integrated in the hydroxy form. So there has to be a hydroxyproline and there has to be a hydroxylysine. All right. And there is another amino acid. So as a result of which, this hydroxylation has to be done. This hydroxylation has to be done of the two enzymes. That means proline and lysine. So proline as well as lysine are needed to be hydroxylated. This hydroxylation is achieved by the enzyme hydroxylase. All right. And the cofactor for this hydroxylase enzyme is vitamin C. So it is the vitamin C deficiency which is not responsible. Just imagine, if the vitamin C is deficient, then there will be no formation of the matured lysine and the proline, as a result of which the collagen which is created is going to be a defective type of the collagen. And that is the basic pathophysiological mechanism behind scurvy. So they have asked about the pathophysiological mechanism behind scurvy. So it is the impaired collagen synthesis, which was obviously the answer for that question. Just a recall, we are not able to get the rest of the options, means linking of the collagen must have been there. Or other defects of the collagen must also be there. But this is really what is happening in case of scurvy. All right. Because of vitamin C deficiency, hydroxylation is not getting achieved, as a result of which the type 1 collagen is not the normal type of the collagen which is being created. It is an impairment or the impaired type of the collagen which is being created. Now, a patient who presented with the Bolex, so they gave you a genu varus deformity. All right. So they gave you a genu varum, and then they asked that what is the possible reason for this genu varus deformity. All right. So multiple vitamin deficiencies were provided. Obviously, it is because of the vitamin D deficiency. You already know that a child who is suffering from rickets, and in our setups, we are having nutritional deficiency rickets most common. That is vitamin D deficiency rickets most commonly. So when the child starts walking on the weak legs, all right, because of the inner compressive cortices, there will be a gradually developing varus deformity in case of a child because of vitamin D deficiency. So it requires the long pathophysiological mechanism. You already are aware of it. Hopefully you have marked the very correct answer for this particular question also. Already you are aware that rickets, in case of the child starts walking, when the child starts walking, so there is a possibility of knee abnormalities. All right. So those knee abnormality, that means structural knee abnormality, could be of two types. One is when both the knees starts pointing towards each other. All right. This is one possibility. And this is valgus abnormality. And the other one is when both the knees are pointing or starts pointing away from each other. So this is the varus abnormality, valgus or varus. All right. Because the patient is walking on weak kind of the bones, as a result of which this thing happens. And it is because of rickets. That means it is because of the vitamin D deficiency. So hopefully everything is clear related to the questions which were asked in orthopedics. Hopefully the session was helpful. Hopefully what we have taught over this period of time was helpful. Hopefully you have marked the correct answers, and hopefully you are going to get the seats in your counseling for this examinations also. All right. So thank you very much for listening this, and in case if you are having any doubt, you can reach the coordinators of the Allen. All the best for your future endeavors. Thank you.